So I'd like to introduce our Health Force 2050 panel, starting with Kelsie George. Kelsie is a policy specialist with a health program at the National Conference of State Legislatures, where she focuses on health workforce policy. She's worked with state legislators and staff on a variety of health topics, writing policy publications and conducting research. And she's previously worked in academia, translating research for those policymakers. So welcome, Kelsie, sorry. Dr. Debbie Jones, who has been a wonderful partner to us. She has been an educator for more than 20 years. She specializes in programmatic design, strategic planning, and organizational management. Currently, she's serving as a superintendent of the Bentonville Public Schools. She previously served as an assistant commissioner for learning services at the Arkansas Department of Education and as principal of Bryant High School. Welcome, Dr. Jones.
Thank you.
Cody Waits, last but not least. Cody is a senior government engagement manager at Transfr, which is a leader in virtual reality-based skills training. At Transfr, he is helping to build the future workforce of every industry through hands-on training using immersive technology in partnership with schools, businesses, and governments. And previously, he served as the director of the Office of Skills Development, part of the Arkansas Department of Commerce. So a great panel to start with. So I'm going to throw out our first question for you. Bear with me. This one has a little bit of setup to it. We have a clear healthcare access divide in our state. In terms of primary care physicians, as of 2018, urban communities in our state had 17.9 physicians per 10,000 residents, compared to their rural counterparts having only 6.9 physicians per 10,000. In terms of dentists, we have 5.7 dentists per 10,000 residents in our urban communities, with only 2.9 in their rural counterparts. 6 of our 75 counties have no dentist at all. So do we have a path forward to address current and emerging healthcare deserts in our state? And I'll open it up to who would like to speak first.
Sure, I'll start. So as of 2 weeks ago, I moved into this role with Transfr Inc. out of New York, but previously, as was mentioned, I ran the Office of Skills Development at the Department of Commerce, and we made strategic investments in the Arkansas workforce across all industries. And just a couple of weeks ago, one of the last things that we did within the agency was pass a bill or pass some funding through the American Rescue Plan Act that allocated $25 million for organizations across the state to be able to invest in private-public partnerships. They call it the ALIGN program, which is Arkansas Linking Industry to Growing Nurses. Those funds are being made available to communities, independent universities, colleges, post-secondary K-12, business partnerships to build pipelines, to build capacity, to allow for more education and training within the healthcare space. We talk about it in terms of growing nurses, but we also talk about it in terms of increasing that pipeline to the nursing profession, which obviously yields a better opportunity and a pathway for somebody once they're an RN to go forward and get that additional degree and those attainments to whatever occupation they may see fit. So, in terms of growing that capacity and helping to alleviate the deserts in which we have in our very rural parts of the states, whether it's eastern Arkansas or southern Arkansas more specifically, and still yet in north central Arkansas and other parts of the state, there are opportunities that are out there in the very near future to be able to start addressing some of these shortages from a statewide perspective. I would encourage all of you that are in some form or fashion a stakeholder in this to begin looking at that as the RFPs will be coming out very shortly.
Excellent. So I'll put a little different twist on it, Dr. Jones, for you. What are you seeing in this generation of students that you expect to change our healthcare workforce?
Sitting in the room, I had the fortune to sit next to 3 of our students I didn't know were coming today. And I thought, we're not the smartest people in the room. When you worry about the next generation, trust me, they're smart and they're capable. They can do so many things, but we have to create those opportunities for them. And if we want to be rich with healthcare workers, we have to create the environment for that to happen. And it really takes, when you said that we're a catalyst, we have to work together to make this happen. And we're doing it in Bentonville, and I'm not taking credit, but Wendy Broughton, who's also here, she began the medical program in 2017 in our Ignite program. And we could not do it without the partners of our businesses. And so today, we have over 100 people in our Ignite medical program and many more on the waiting list to get in. And these students are getting real opportunities to be in surgeries, in childbirth, in ambulances. They're getting the real experience, and they're doing very well. When we started the program, some industry might have been hesitant to take our kids, but today Mercy hires Ignite CNAs at 16 years of age. And trust me, they're doing a great job. In order for this to happen in your community, first of all, you have to work around all the bureaucracy, and you can do it, but it can take a business, a medical professional going to that local high school and saying, let me partner with you to produce more healthcare workers. We don't know how to do it. It's okay. Let's go visit a program that is doing this well, because there are models in our state doing this very well. And we have to introduce kids to the concepts to get them engaged much earlier in junior highs, in middle schools. And we, just like we're having to grow our own teachers today, we can grow more healthcare workers, but it does take collaboration, because you can't expect teachers who are not in the healthcare field to truly understand the healthcare field as nurses and doctors do. And I think you'll get our students to agree. It is those partners who have inspired them to go to the next level.
Very encouraging. Thank you. Kelsie, we're going to take advantage of your national experience. So if you could just share with us, are these challenges common with other states, or are we unique? And what have you seen in those other states that have helped the situation?
Yeah, thank you. So the National Conference of State Legislatures represents legislators and legislative staff from across all 50 states, commonwealths, and the territories. So we have a big national view of what's happening, and I think, to no surprise to any of you, health workforce shortages are fairly common across the country, and it's not a new challenge that we've seen, but the COVID-19 pandemic and public health emergency definitely exacerbated a lot of the challenges that we're seeing. I would say that we're seeing states emphasize assessing workforce challenges and really trying to understand their local context and what is happening within their states, which also provides a baseline to then measure policy interventions against. So we're seeing states move beyond just counting heads through licensure processes to really understanding who is providing what type of care, to whom, and where. So one example from a national perspective, the Health Resources and Services Administration funds several health workforce research centers from across the country, and the Mullen Institute at George Washington University is one of them. And they recently launched a Medicaid tracker tool. And this tool looks at not only the number of primary care providers, and you can look at the state or the county level, but also drills down even deeper based on Medicaid billing data to show which providers are treating Medicaid enrollees or have billing history from treating Medicaid enrollees. So it's not just about who's licensed to provide care, but who they're providing care to. And this is just one of several tools from those health workforce research centers that I mentioned. And moving more to what we've seen in the states, we've seen several states enact legislation to gather more accurate information to better understand what's happening within their borders, and to inform the health workforce development initiatives that they choose to pursue. So Indiana is an incredible example in this space. In 2018, they enacted legislation requiring information gathering on certain health professional fields when a health professional goes online to renew their license. And the state contracted with the Bowen Center for Health Workforce Research at Indiana University of Medicine to develop and maintain these workforce renewal surveys, to create data management strategies, and to regularly report on that health workforce data to the legislature and to the public. So from this data, they were actually able to identify those dental health deserts, or health professional shortage areas is the federal designation from HRSA. And that really opens up the pathway for federal funding mechanisms that require a health professional shortage area designation for certain health workforce initiatives. I'll also share that Utah passed very similar legislation last session looking at health workforce data collection. And they also enacted legislation requiring the review of every licensed profession in the state every 10 years. So making sure that the licensure requirements meet what actually needs to happen and that they're able to set the right balance of regulation to make sure that folks are not facing too many barriers when they're trying to enter those professions. So through this analysis, they've started with behavioral health as their first segment of the workforce that they're focusing on. And they identified that most of the licensed professions in behavioral health require a master's degree or higher. But that creates a gap when most of the students that they're educating or most of their graduates are from baccalaureate or associate's degree programs adjacent to behavioral health, and creating a pathway between that bachelor's level or associate's level to those higher level requirements for licensed positions. So they're actually looking at creating a behavioral health technician position. That's a new licensed occupation in the state that would be at the baccalaureate level. To fill those gaps within the behavioral health career ladder. And this is like I said, this is an entirely new position, so it has its own scope of practice, and it's not meant to replace those licensed professions that are, your psychologists, psychiatrists, licensed social workers, but it's meant to extend their reach and provide support to them so they can focus on the clinical interventions and really create a pathway for those folks from throughout the educational spectrum.
Great.
I would like to touch on that real quick. So, in Arkansas, one of the things that we've been doing recently is, looking at how do we bring it down something to what Debbie Jones was talking about in terms of getting kids involved earlier, getting them certified, licensed earlier. And at Arkansas, we have 3 areas in the state now in which we're licensing 18-year-olds coming out of high school as a practical nurse. Prior to this, just this year, the only place that was doing that was the University of Arkansas in Fort Smith. Now it's South Arkansas University in El Dorado, East Arkansas College in Forest City. And part of the plan moving forward is to how do we get that statewide, right? And so if you talk about the pipeline, there's roughly 60-something hundred active nursing students in the state at any given time. Probably 5,000 of those are kind of in the higher level RN or above kind of nursing programs. From a PN perspective, you've got 1,100. And while we know that PNs are heavily used in some areas and not so much as the other, it's also a really good opportunity for students who are interested in the healthcare profession to get started on that track at a much sooner age, start making a livable wage, and really figure out if that's the track they want to be on. Another piece to this that I think is interesting enough in terms of just getting students involved earlier, from the Transfr perspective, we have developed simulations that are based in VR using an Oculus headset or a Lenovo headset or whatever the case may be, that align 90% with the standards and curriculum aligned with CNA, medical assistant, and things of that nature. So when we talk about meeting that student where they're at in the future of the workforce, right? Students learn different than they did in the past, and be able to leverage technology is of interest to them. So what we've done in terms of developing that pathway is creating those simulations, giving them access to it from a career exploration perspective, but also to be used as supplemental training aids in the classroom. And we're planning on developing that out into the PN professions and RN and moving that along across a number of different occupational areas. One other piece that I'll mention real quick just around the workforce, issue that I've been dealing with for probably the last 18 months in my previous capacity was, when you look at ratios of states in terms of the education and training programs, right, there's really no set standard at a national perspective. It's really up to the states. Some people may say that's good. Some people may say that's bad. That's a conversation to be had. But if you look in Arkansas, right, so it's an 8-to-1 in an acute care setting, 10-to-1 non-acute care, 12-to-1 in a community setting from some of these ratios, right? And so what that does is in some cases, it limits capacity of an institution of training or an education provider at a post-secondary institution from enrolling more students because they have to limit this capacity ratio when they go to do their clinical rotations. And so from our perspective, right, we want to see some standardization around that. We also want to see some standardization around the number of clinical hour requirements that are done, because right now that's very flexible and nimble. Most of the states kind of set their own thresholds, but there's really no set standard across the country, and even in Arkansas, by institution, it's always different. So there's just a number of different factors that impact enrollments in post-secondary education nursing programs, as well as other healthcare programs across the state.
Thank you. I would just like to draw your attention to the QR code that you see on the screen. We will have an open question session. So if you have a question you would like to submit to anyone on the panel, please go ahead and scan that QR code with your phone, and you can submit your question. So we're talking about the students, and very fortunate to have some of your students here. What age groups should we begin nurturing the interest in the healthcare field? I mean, we've talked about high school students, but is that...
I think you have to look at it as a continuum. At the early, even at elementary, when you start talking about professions and people in the community and what they do, you really start there. But as we move up through the middle grades, and certainly by the time you're in junior high, they need to be more knowledgeable about the fields. They really need to have activities and clubs related to potential careers. And then, like the students, by the time they're in the 10th, 11th, 12th grade, they need real experiences. And I think the key to this is it's not the textbook experience, because that's not the career experience. You can't duplicate the real work of the field, no matter how good the teacher or how dedicated the teacher. They have to be in your businesses. What we're offering, and I think most school districts superintendents will say the same thing: let us be your pipeline. Let us be your future workers. If you can see the value and it's all within your school districts and you make those connections, then you'll invest in that. And our partners have definitely done that with our students. They've taken them on to mentor them, like the 3 students here, doing some college level data work with professors. They're studying the markers of heart disease. And so when I say the smartest people in the room is the next generation, they truly are. But we have the expertise in the field, in the careers. We owe it to the future to pass this on to them. And so it has to start early. It has to be planned, deliberate activities. We have to do a better job within the whole state of taking real activities to kids in the classroom and take the kids outside the classroom to let them experience that. Because Wendy will tell you, some kids will go into the medical field and first time they have to draw blood, realize, I don't like this profession. And that's okay. They just saved their parents lots of college debt, right? And so it starts before college, and we owe that to kids. And if you want to truly engage kids and get them to want to be successful in school, give them career experiences.
So one of the questions that's been submitted is, how do you see the behavioral health tech positions comparing, say, to a registered nurse? And would it replace RNs in the behavioral health environment or augment them?
So it's my understanding at this point that the behavioral health technician would be a position to extend already existing providers operating in that space, whether that is a psychiatrist, psychologist, or a nurse trained in behavioral health. So it's not meant to replace those already existing licensed positions, but it's meant to allow them to focus on their full scope of practice and the clinical interventions that they're able to provide, and really extend their work and their capacity to serve more individuals.
So this one is a little bit different than what all of you do, but I want your opinion. One of the greatest challenges in the workplace today, outside of healthcare and within healthcare, is retention. Mm-hmm. A tremendous amount of money is spent on training and building the skill sets to then lose those workers. What do you all see as what this generation is really looking for in a workplace situation? Is it benefits driven? Is it recognition driven? What are you seeing in that area?
Yeah, I'll start. So I just transitioned from state government into the private sector into a software tech company based out of New York. And so the dynamics are pretty much night and day. But what I can tell you is the average age of our workforce is I'm 38, right? It's, 25, 26 probably. And, it's interesting, the conversations that we have around, feeling like it's more of a family than a business, right? They talk about on a daily, weekly basis, there's time for people to talk about what's going on in their personal and professional lives. They're talking about how to become better leaders, how to grow within the organization, and not that that's too dissimilar from any businesses or companies that are represented today, but it does bring a different dynamic and perspective than perhaps what I came from within state government, where we're very focused on outcomes driven and making sure that we're making sound, fiscal decision making, and not so much always taking and tending to the needs of individuals. So, I think for one is having that sense of family and having that sense of belonging and really having a purpose-driven employment. And I think that's really what the younger generation is feeling, is this purpose-driven effort. The other piece that I would mention around just from a previous perspective is from a turnover and retention ratio, what we've witnessed around a lot of hospitals and healthcare providers here in Arkansas, National Park Medical Center, Saline Memorial, Ashley County, a number of others, have really started putting in a residency nursing programs, right? So 1-year resident nursing programs through the apprenticeship model, right? And so what that does is it allowed our agency to offset funding associated with that expense by leveraging national federal dollars for apprenticeship and state funds for apprenticeship. But what we saw was about a 60-something% turnover in those newly hired nurses coming out of college. And now that retention is, that turnover rates dropped from like 60% down to 20%. And so from a cost perspective, and what you're seeing at hospitals across the state is that they're really looking at these 1-year residency models to help reduce that turnover rate.
Mm-hmm. And I would just add that I think during the public health emergency, we saw a lot of problems that have existed in healthcare occupations come to light, and a lot of challenges that have been ongoing really exacerbated to levels that we had not seen before. So, burnout, moral injury, violence against healthcare workers, all of these things are really changing the landscape of what healthcare professions look like and the work-life balance that's needed to manage that sort of environment. So creating mental health supports for healthcare workers so that if they do experience violence in the workplace, they know how to respond, they know what resources are available, and they have the mental health support too. I would also say that there was a recent study that came out of the University of Washington that looked at turnover rates in healthcare occupations. And pretty much every occupation within healthcare has recovered to pre-pandemic turnover rates, except for direct care. So those are your personal care aides, your home health aides, and your certified nursing assistants. And those positions are predominantly held by women of color. They're also 45% of direct care workers tend to live at poverty. The majority of women of color in those positions are actually on medical assistance or food stamps or some form of aid. So states are looking at strategies to address that income piece of it and making sure that wages are there to support them in those positions that have fairly significant training requirements, but may not have the same wages as something in customer service where you can go and not have the same stressful environment or the same training requirements that you may have in a direct care setting, like nursing facilities, assisted living facilities, or home health. I would also, again, echo the importance of career pathways and creating a clear career ladder for retention, especially in direct care. When folks come into these positions, the majority of them cite that there's no room for growth, and low wages often push folks out of that workforce. So how can you create pathways from CNA to LPN to RN and really facilitate a career ladder for someone so they see themselves in this position as a career and not as a position to put food on the table for the moment. And we've seen a lot of states do this. Like I mentioned, Indiana did a lot of health workforce data analysis, and out of that came that they realized most of their CNAs or most of the LPNs that were getting licensed were CNAs previously. So how can they create a better bridge, especially to increase the diversity and representation within that workforce? They created a bridge program between CNA and LPN and RN to help facilitate that.
One of our questions that's been submitted is definitely a pressing matter in our state. The things that we're talking about will help smooth the path for the young professionals to enter the healthcare workforce. But as a state, one of our biggest challenges is the disparity between urban and rural. Mm-hmm. So do you have any suggestions for how we might be able to encourage and incentivize the future healthcare workers, practitioners, to go into those rural markets and stay in those markets?
I think it's fascinating. The very same challenges that we face in getting healthcare workers is the same with teachers. Yeah. They can't work remotely. They have to be face-to-face. And all of those things you talked about, the belonging, having a relationship, having flexibility, having a career ladder, all apply to what we're doing for recruitment and retention for teachers. But the other piece that we're doing is you have to grow your own, because they're more likely to stay within your community if they feel like it's been a good community for them. And I think that we're going to have to do that with some of the rural communities as well to keep healthcare workers.
Yeah, and I would just say, I mean, and Sue Tedford and I at the State Board of Nursing had many conversations around the whole ratio piece as it relates to education and training and whatnot. But, I think sometimes the ratios we put in place hinder a growth in those occupations from a private sector employer's perspective. Again, if you look at different states across the country, like 20-something states have an 8-to-1 ratio in terms of their clinical rotations in acute care setting. Why not increase that at a statewide level so that allows our enrollments to increase at our post-secondary institutions, putting more students in the pipeline, and then allowing the private sector employers themselves to dictate whether or not they want to increase those ratios at their own facility. So, I think there's some policy changes we could make that would at least open up perhaps some of the bureaucracies that we have in place. And I know there's legislators and groups working on that, but, that's something I think that would really help our rural communities, as well as trying to figure out ways to incentivize teachers to go into those rural communities and be at those education and training organizations. We talk about incentives and teacher retention bonuses and the fact that the turnover ratios in our teachers of healthcare professions aren't where they're at. We also don't necessarily compensate them as well as we should either. So I think there's a number of different factors that we have to look at in an urban setting versus a rural setting.
And I would also add that family medicine residents who spend at least 50% or more of their training in rural settings are more likely to practice there. But when you look at residents who come from rural areas and have a residency training in rural areas, they're far more likely to practice in rural communities. So there's sort of this factor of recruiting from those rural communities and showing them these opportunities that they may not have otherwise exposure to, but also creating those rural residency options, especially for physicians, can encourage and actually is shown to increase practice in rural communities. And part of that is sort of complicated by the closure of rural hospitals and access to healthcare in those settings. So there are several states that are looking at graduate medical education and residencies in community-based settings. So looking at rural health clinics, federally qualified health centers. New Mexico, for example, has a grant program for tribal health centers, rural health clinics, and FQHCs that actually provides GME funding to create a startup residency program so that you're able to have more residency slots in those rural communities in the facilities that already exist there.
Neat. Well, unfortunately, we are out of time for our panel, but thank you all so much for sharing your insight with us.